We're going to go ahead and get started. Um, Ready? Today we'd like to welcome Dr. Sara Espinoza. Dr. Espinoza, some of you have probably already have worked with her. She came to my attention several months ago when Dr. Figueroa emailed me saying we need to get her out here to speak to the transplant grand rounds because her area of interest is directly related to certain issues that all our transplant programs are facing right now with some of our older patients. So as you can see, she's Associate Professor of Medicine here at the Health Science Center and a faculty member with the Barshop Institute for Longevity and Aging Studies. And again, she's an expert in frailty, has research and publications in the area of frailty as well as in the area of transplantation. And she's going to be speaking to us on the implications of frailty on the transplant patient. So, Dr. Espinoza. Sometimes your hair will, but that's okay, we'll figure it out.
Thank you. Okay, can everybody hear me? Okay, great. Well, thank you for inviting me to speak with you. I am an internist, so I'm sure you guys know what a geriatrician is, but a lot of people in the community don't know, so I always start by defining what is a geriatrician. So I'm an internist. I did internal medicine residency, and then after that I did a fellowship in geriatrics. So I practice as a geriatrician. I mostly see older patients. And I have been interested in frailty since I was a resident. So as medicine residents, we become machines at admitting sick people. And probably around my second year of residency, I just kind of started to, like, you walk into the ED to admit a patient and you're like, ooh, this person's not gonna do good. And you can just tell by that one look, and you guys all know what I'm talking about. So I just became interested in that idea, well, why can I pretty much tell within 5 minutes that someone is frail and they're not gonna do well? And so from that point on, I became interested in the concept of frailty, and I've spent the last 12 years doing my research in that area. So what I did for you today, so I met with Dr. Figueroa and his staff earlier because he was kind of interested in applying frailty, or at least some concepts of frailty, to the transplant population. So what I'm gonna do for you today is, initially, we're gonna go over frailty, what is frailty, kind of give you that background. And then I'm gonna talk to you a little bit about what's already been done in the surgical population with regards to risk stratifying older patients for surgery and outcomes after surgery. But then actually, I was surprised to find that there's actually a fair number of papers using frailty in the transplant population. So more or less the second half of the talk is I'm reviewing that literature for you, and then I'm available to talk to you more after this if anybody's interested. I've already met with Dr. Figueroa's staff, and we trained on how to do some of these measures. So anyway, I want this to be helpful for you in your patients that you see. Okay, so what is frailty? People sort of say, well, we know it when we see it, but not everybody sees the same thing. So it wasn't until probably the last 15 years or so that people actually, especially geriatricians, really made the attempt to put forward a definition for frailty that everybody can agree on. Now, it's still controversial and there's multiple definitions out there, but I'll review some of that with you in a minute. But basically, frailty is considered a geriatric syndrome. So people who are frail are just highly vulnerable. Any little thing just pushes them over the edge. They're highly prone to becoming disabled, falling, nursing home placement, disability, I said that already, hospitalization, and death. And so the picture you see is sort of someone who is sort of doing okay at home, few medical problems, maybe a little disability, but kind of hanging in there, sort of on the edge, and then some kind of insult occurs. Either they get sick with something, or even a change in their environment. The caregiver that used to come and check on them once a day is no longer doing that. And then they kind of start their decline, and then they're in the hospital. And then once they're in the hospital, these are the patients that get delirious, and they're pulling out all the lines, and they're causing us all kinds of problems, and they get kidney failure on that, and then they're falling, and long story short, then they just sort of start this spiral of decline. And then they never quite get back to where they were before. So they might recover from that, but they're never quite back to where they were before, and then another thing happens, and another thing happens. You guys have probably seen these patients before. So as I said, this is sort of a concept, a syndrome, but really hadn't been defined until probably the late 90s. So this is work done by Linda Freed and Jeremy Walston, who are people that I trained under in my fellowship, and they were the first to try to put a definition of frailty out there. And this is sort of like a conceptual model, and so this is sort of what they base their frailty definition on, but their idea was that aging and disease both lead to primarily muscle mass, loss of muscle mass, sarcopenia, and this leads to decreased strength and power, low VO2 max, low resting metabolic rate, which we can potentially measure as low walking speed. That leads to disability. This goes back to low energy expenditure, undernutrition, back to sarcopenia. So they called this the cycle of frailty, and it's sort of a vicious cycle that once you kind of enter this, it's like one thing begets another, and it's really hard to recover from this. So based on that idea that frailty is this sort of cycle of bad juju, I'll say, they tried to operationalize and put forward at least a research definition for frailty. And what they put forward was frailty was the presence of 3 out of these 5 characteristics. Unintentional weight loss of 10 pounds or more in the last year, which you can either get from reviewing the chart, but the way they did it actually was from a cohort study. I won't go into all the gory details on that, but these subjects were not actually patients. This was a longitudinal cohort study. But so unintentional weight loss, self-reported exhaustion that they got using some questions from a depression scale, low physical activity, which they got from a questionnaire, a physical activity questionnaire, weakness, muscle weakness, so trying to measure that sarcopenia using a handheld dynamometer, very easy. I think you can buy them for like $150 from Amazon. But anyway, they measured that, and then slow gait speed, and they used a 15-foot walk. You just measure out 15 feet. You ask people to walk at their usual pace as they would normally do. If they use a walker or a cane, they can use that, and you time them. And they had to standardize these things across the cohort. So this was done in the cardiovascular health study, and they had about a little bit over 5,000 subjects. So they used the norms within that population to define, well, what is a slow walking speed? What is a low grip strength? And I can get to that. I'm going to get to that a little bit later. But they said if you have 3 or more of these, you're frail. If you have 1 or 2, you're intermediate or pre-frail. And if you have none, you're not frail. And so then they looked at survival in this cardiovascular health study over 96 months. And if you can see here, the top dark line are the people who are not frail. And their survival is better than the pre-frail or intermediate people here. And their survival is better than the people who are frail. So the bottom line are the people who are frail, and you can see that their survival is pretty horrible over this period of time. And this was done using Cox proportional hazard model, which was multivariate. They included all kinds of other variables in this model that would account for mortality. So it was a very robust finding, and this was the first paper to kind of try to define frailty and also say, hey, we can define it, but we also can show these people are going to die. I know that's so crass, but okay. And so many other studies actually validated this. So this was the first in 2001, and several other cohorts have now validated this model. But one thing I want to point out, because I think it's very commonly confused, even I think among geriatricians to some extent, is that frailty is really I say classically, not considered the same thing as disability and comorbidity. They're kind of considered three distinct entities. People often confuse them. So, but they're interrelated. So, so this is a diagram from that paper in 2001, the same paper I just showed you, just trying to show you that there's overlap between these three things, but that there is some distinction. So basically, only about a fifth of the cohort shared disability, comorbidity, and frailty, meaning they had all three of these things. And by comorbidity, we define that as just the presence of two or more commonly age-related diseases like hypertension, diabetes, heart disease, stroke, that kind of thing. And disability was defined as difficulty performing one or more basic activity of daily living. So bathing, dressing, toileting, that kind of thing. And so you can see only about a fifth of them had all three of these things, but over a quarter of the people who were identified as frail using the criteria I showed you had neither disability nor comorbidity, but they still had that increased risk for death. So it's just to show you that there's overlap, but they're not really the same entities. So what is the prevalence? Like, how many people out in the community are frail? Well, it kind of varies on the cohort that you're looking at. And I should just say real quick, this is a model that's used in research a lot. I mean, there's probably now thousands of papers out there using this definition and other definitions for frailty. But at least in geriatrics and even medicine, we haven't yet fully translated that to the clinic. So in other words, I watch people walk and I can sort of tell if they're slow or not, but I'm not, in my clinic, we don't time people walking. And that's a real, I think, an area we need to move into. I actually think after reviewing the papers that I've looked at, the surgical research and the surgeons and the transplant surgeons have done a better job translating this to the clinical population. Although now I see there's actually, after speaking with Dr. Abrahamian this morning, there's financial ramifications there. So now it's like kind of making sense, but okay, I'm going off on a tangent. But my point is that this data for frailty prevalence is coming from research studies. So in the cardiovascular health study, which is that first cohort that I went over with you, the prevalence was actually kind of lowish. It was around 7%, I believe. And then these are other cohorts. This is the Women's Health Initiative, is a little bit higher. This is a cohort here in San Antonio. It was about a little less than 10%. And then this is another Hispanic APESI cohort consisting of all Hispanics, and you can see the prevalence is about 20%. So the prevalence actually kind of varies based on kind of the ethnic makeup of your cohort. And I should say that most studies have found that frailty prevalence is higher in ethnic minorities. So Hispanics, Mexican Americans, African Americans, the frailty tends to be higher. So one thing I want to just point out too is that the prevalence of pre-frailty is actually pretty high. So in this cohort study, almost half the people that they looked at were pre-frail, meaning they had one or two of those frailty criteria. And I just point that out because you see that although they're not as at high risk for death as the frail population, there is still some risk there, and they make up a pretty decent proportion of the population. And I should say that these cohort studies are all community dwelling older adults. These are not nursing home patients. These are people living in the community who are over 65. Okay, so I want to keep an eye on time because I want to have enough time for you guys for the end, but I'm just want to just tell you that I did a lot of work with frailty in collaboration with Dr. Helen Hazuda, who is the PI of the San Antonio Longitudinal Study of Aging here, and she had initiated a cohort in the early 90s looking at predictors of disability, but frailty had not been defined in this cohort. So when I came here from fellowship, that's what I did. So I'm just going to share a little bit of that data with you just to show you that frailty is definitely correlated with disability. So this here is just showing you how many people in each frail category have ADL disability, which are self-care activities, and then IADL disability, which are things that people need to do to maintain themselves in society. So driving a car, shopping, taking their medications, using the telephone, that kind of thing. So if you look, if you're non-frail, your disability levels are kind of, like a little less than 20% for ADLs, kind of pretty high for IADLs. But as you go up on the frailty category, you can see that your disability rates are increasing. And we also found that actually the number of days spent in the hospital over the last year is correlated with frailty as well. And so you can just see the people who are frail are actually the ones using our healthcare services much more than the non-frail. And then this is our Kaplan-Meier survival curves from that population, where we found very similar to what Linda Fried found at Hopkins, but basically that the survival for the non-frail group is better than the pre-frail, and in turn that's better than the frail. And this again is an adjusted model. So, and I already mentioned that this kind of thing has been replicated in other cohorts. So our findings weren't unique, but it was a different cohort that had actually a half Mexican Americans in the cohort. But just getting to that mortality data, you can see that over half of the people who were frail in the SALSA cohort were dead within 10 to 12 years. And we only had mortality information at that time, but I would venture to guess that if we looked at it, 5 years, we would have found similar thing. So, and so this just puts sort of a number on it. This is the hazard ratio for death in the frail compared to the non-frail. And you can see that if you are frail, you're over 2.5 times more likely to die over the follow-up period than if you're not frail. And we adjusted for all these other things. I want to also mention, I'm trying as I go to think of nuggets that will help you in your patient care, but basically other things that have been associated with frailty is actually lower socioeconomic status. We know lower SES people have a higher prevalence of frailty, and we also know that's correlated with higher mortality. So we adjusted this for socioeconomic status, but we still found that frailty predicted death very significantly. Okay, so I'm always seeing an older population, but you guys see younger people, and I know you guys, your patients are, have, severe organ damage, so probably a lot of them are frail. But in a person without, needing transplant, what are the kind of things that increase their risk of becoming frail? Well, they're all here, and this information we know from the Women's Health Initiative study. But higher age, low income, as I already mentioned, and this is a very interesting finding. So historically, I mentioned that frailty is associated, one of the 5 characteristics is unintentional weight loss, right? So when frailty was first sort of conceptualized, it was thought of as like a wasting syndrome. But now, in the last, I would say, 10 years, more and more data is coming out that, yes, while being underweight or losing weight is a big, huge problem and will cause you to become frail, we now know that obesity is just as bad and increases your risk for frailty. And actually diabetes as well. So I'm not going to go into this, but that's a huge focus of my work right now, is to look at the relationship between obesity and insulin resistance on the onset of frailty. But other things are depression, falling, some of these comorbidities, and so forth. So these are things that we can hopefully impact at maybe more of a middle age so that people don't become frail as they get older. The strongest predictor of frailty, however, is being pre-frail. So if you already have 1 or 2 of those 5 things, you only have to get like 1 or 2 more and you're there. So in our study, well, I'll just show you this. This is the SALSA cohort. If you were pre-frail, you were over 3 times more likely to become frail over, this was about a 6 to 7 year period. So that's why I really like to hopefully make that clear that although the pre-frail people are not like super high risk, they're high risk for becoming frail. And then, so I think that the people who are pre-frail is actually a population to intervene on. So maybe I don't need to go into huge detail, but I'll just show you here. This is people, what their baseline frailty status was in the SALSA cohort, and then this is what happened to them about 7 years later. And you can see in the frail category, most of them died. And the majority stayed who didn't die stayed frail. Some actually got a little better, got better. So people do kind of progress and go back and forth between categories. But if you're frail, the overwhelming event is to die. But you can see in the pre-frail group, while the majority stayed pre-frail, a pretty good proportion became frail or died. But more people actually went back to non-frail than in the frail group. So in my view, I see this pre-frail category as a group of people that are really amenable to interventions. Okay, so why are these people frail? What's going on? There's been a whole lot of research, including actually animal research here at the bar shop and other places, trying to understand why people are high risk for all these horrible outcomes if they're frail. And I'm just trying to summarize in one slide, but there's been a lot of studies showing that there are physiologic alterations in people who are frail, including inflammation, glucose intolerance, low IGF-1 and DHEAS, which are like sex steroids or sex hormones, high cortisol levels. And it's thought that these kind of physiological alterations are leading to the phenotype which we measure with the frailty phenotype, and then to these bad outcomes which we want to prevent. But why that they have this and what the interaction is with disease is not really known, and there's a lot of research going on in that area right now. So I'm just going to probably for the in the interest of time skip this, but just to suffice it to say that I did some biomarker work in relation to frailty here, and just suffice it to say that we also found that frailty was associated with increasing levels of inflammatory proteins and like IL-6 and fibrinogen and transferrin. So you can see that the levels of these inflammatory proteins increase across frailty status. And this data came from community dwelling adults here in San Antonio, actually at the Air Force Villages study. I'm sorry, Air Force Villages, which is now Blue Skies of Texas. Yeah. So they opened it up now to non-military people. Okay, so I've probably bored you to death, but I feel like you need to have that background on frailty, and now hopefully we're getting to a part that you're more going to be interested in because it's going to apply to your patients. So can we apply this frailty model to surgical patients and transplant patients? And as I say, I really do think the surgeons have done a better job moving this research to the clinical setting. So I'm going to review that for you now. So actually, if you think about it, surgery is actually a really good, I don't know, I want to say stressor, but I mean, it's a huge stressor, right? So if you think about the concept of frailty, it's vulnerability and inability to tolerate stress. So people undergoing surgery, that's obviously a huge stress. So how they do there is almost sort of like the main definition of frailty. So I found this from a paper in critical care, and I don't know, it's just I was trying to kind of portray or illustrate, how people respond to stress. And this is supposed to be sort of like all physiologic parameters that you would follow in a patient. But initially after a stress, according to Cole and Deutschman, your initial energy requirements go down because you're trying to accommodate the stress and prepare for the stress, and then things go up into a kind of a flow and then resolve, and then you're kind of back to your steady state. And this peak here is supposed to be proportional to the severity of the injury or stress. So in this paper, they said, if you don't handle this stressor of surgery or injury well, this is sort of what happens. So you have the initial ebb and then the flow, and then you just don't come back down, and you kind of keep, you kind of go down a little maybe, but then you go up, and then you may develop into multi-organ dysfunction syndrome. I mean, this was more in a critical care setting, but I think we see this in our patients all the time after surgery, at least the ones who don't do well, that they kind of never quite get resolution and then go on to potentially chronic critical illness. Okay, so actually back in 2010, this is a surgeon at Johns Hopkins who I actually knew, and I knew when I left Hopkins in, gosh, when was it, 06, And we had discussed this, and he was working on this project at this time. But basically what he did was apply the frailty model to older patients who were undergoing any kind of elective surgery at Johns Hopkins. And what he found is that frailty predicted postoperative complications, length of stay, and discharge to nursing home after the surgery. And predicted pretty well. So, you know, if you were frail, you were over 2.5 times more likely to have a complication postoperatively. And gosh, I believe it was like within 30 days. And then the length of stay was longer if you were frail, and you were really highly likely to go to a nursing home if you were frail. So I think if I'm correct, this is probably the first paper to look at frailty in a surgical population. So what are we talking about then? Okay, I've given you the definition of frailty, but like what are we actually measuring? So this is from another group, and this is the group that's done the most work in transplantation, but basically I told you that we standardize these measures to certain norms. So grip strength we standardize to body mass index, because the thinking is that the higher your body mass index, you should have a higher muscle mass, although at some point that may not be true because we have sarcopenic obesity. But they standardize these to kind of BMI categories between men and women. So just taking men, for example, this would be the cut point for low grip strength for a man with a BMI less than 24. And then for gait speed, we standardize to heights, because we know that the taller you are, the longer your leg length and the longer your strides are, and the faster you walk. So these heights are actually the median height for the population. And then physical activity was standardized by sex. So the reason I'm going over this with you is because when I first met with Dr. Figueroa's group, I told them, I have no idea what cut points you would use in a middle-aged person about to have a liver transplant. Because all that I know is that these cut points were standardized in older, community-dwelling older people. I have no idea what a weak transplant patient is versus a non-weak, But this group here actually used the same cut points from that cardiovascular health study, and they found, that it predicted outcomes. So I'm going to show you that. But I guess what I'm saying is you can use the same cut points that we found in older patients. So, and these are published, and I can send anybody these cut points if they're interested. And then for exhaustion, these are, you ask people a question, how often did you feel this way in the last week? That you felt everything you did was an effort or you could not get going? And people who said that they felt that way primarily, yeah, that was me in this morning, right? So we might be pre-frail, at least if we have that one. But people who endorsed this on more days than not had exhaustion. And then this was unintentional weight loss of 10 pounds or more. So, okay. So now, there are actually several papers in the area of kidney, liver, and lung transplantation, and these are the groups that have done it. You guys may know some of these people in these groups, but I'm just going to kind of go over that data with you now. Okay, so the first, actually, this is a woman, McAdams DeMarco, who I actually had the pleasure of hearing her speak at a conference recently. And she's done, I think she has like 4 or 5 papers looking at frailty in kidney transplant patients at Johns Hopkins. And basically she used the same cut points, the ones I just showed you, and she stratified by frail, 3 or more, intermediate, 1 or 2, or non-frail. And some of these lines overlap, and maybe they're not that predictive early on, but you can see clearly by 5 years, the people who are frail had the lowest survival. But even early on, while there's maybe not a huge distinction between the non-frail and the pre-frail here, you can see the frail people are dying pretty quickly. So I think it's a pretty good way to stratify who's going to die within 1 year of your surgery. And then I thought, well, gosh, I don't know how many people awaiting surgery or transplantation are frail. And this paper actually gave you that information, which I thought was pretty cool. So kind of just understanding the epidemiology here. But these are people awaiting transplantation who were assessed for frailty at the time of their kind of transplant evaluation. And you can see that, you know, I guess, let's see, it's a little less than, maybe around 15% were frail, and then, you know, there weren't that many that were horribly frail, but a good 15% at least had three of the characteristics, but then a huge proportion had one or two. So I would say the majority of the people awaiting transplantation were either pre-frail or frail. This was for kidney. And then she also looked at, okay, well, maybe death isn't the only outcome we're interested in, but how about people who can't tolerate the immunosuppressive treatment because they have side effects related to the drug, infection, or hematologic ramifications? And here she just shows that if you're frail, you're more intolerant to having to get a dose reduction in your immunosuppression compared to if you're not frail. So pretty clear distinction all along over 4 years. And so then, you know, when I saw this slide, I thought it was interesting because they did not tell you what graft loss was by frailty, which I thought would be cool. So I'm a cynical person, so I think maybe they didn't find an association. But what they did was do graft loss by the drug reduction, which was associated with frailty. So anyway, I don't know if there's some, you know, scholarly magic going on there, but you know that frailty predicts intolerance to the immunosuppression, and then whether you were not able to take the immunosuppressive full dose therapy predicted your graft loss. So I guess there's kind of a relationship there. I know. I wish they'd show us graft loss by frailty status. I'd be happier. But you can see that if you were frail, you couldn't tolerate the therapy as well. And then if you can't tolerate the therapy as well, you're likely to lose your graft pretty early on. So these are the people who had reduction in their immunosuppression, and they're losing their graft, you know, very, very quickly, and much more so than the others. Okay. So another outcome she looked at is 30-day readmission, which in the medicine world, you know, everybody's trying to reduce that, and I would guess it's the same for surgery too. And this was a separate paper, but by the same authors. I think it's actually cool because she stratified by older people and then less than 65, and then frail versus non-frail. And so in the younger people here, the people who were younger but frail, you know, they were very likely to come back to the hospital within 30 days. And these rates are high anyway. I think the national rate is, or at least local rate is, I want to say it's probably around 10 or 12%, 30-day readmission. But you can see these are higher than that, but if you're frail, you know, it's pretty much double of what if you're not frail. And then in the older population, it's much higher, but, you know, higher in the frail older population. So basically what she showed is that frailty, at least in the kidney transplant patient, is predicting a lot of bad outcomes: death, intolerance to immunosuppression, and 30-day readmission. Okay, so there was one paper that I found looking at liver transplants. So, and it was a bit of a small study, but they used the same exact frailty criteria at UCSF, and they looked at 294 patients listed for liver transplant with a MELD score of 12 or more, and they followed them over a year. The mean age of these people were 60, so they were not necessarily older. But they also measured, in addition to frailty using the Fried criteria, ADLs, IEDLs, and then something called the short physical performance battery. And I'll show you, but they looked at whether these were just as good or better than frailty at predicting outcomes. But what the short physical performance battery is actually, it's sort of like a battery of gait, strength, and balance tests that we do primarily for research. So it involves a timed gait speed, just like the Freed criteria, but it also has some balance tests where you ask people to stand in a tandem and semi-tandem stand, and you time how long they can hold that. So it's a measure of balance. And then the strength part of that is actually a 5-time chair rise. So they stand from a chair with their arms crossed, not using their arms, 5 times as fast as they can, and you time how fast they can do that. It's actually pretty interesting to see people who you think don't look so bad, they have a lot of trouble with that one. But anyway, so that's what they did, and so I just, oh my gosh, I hit the wrong button. So sorry. Woo. Okay, so I just thought it would be, I thought you guys would be interested in knowing what are the characteristics of the frail versus the non-frail, because you guys look at these numbers all day long, I'm sure, right? So actually, these numbers, as far as the things that go into MELD, really tracked by frailty status. So you can see all of these were significant. MELD, total Billy, INR. Well, actually, INR was the only one that was not significant. Creatinine was higher, the sodium was lower, and so on and so forth. How many people had ascites, both any kind of ascites, whether it was mild, moderate, or severe, encephalopathy, and then the child Pew score of C was higher in the frail group. Interestingly, though, in this particular population, there was no difference between the non-frail and the frail with regard to age, ethnic group, sex, why they had liver disease, you know, whether it was hep C or NASH or what have you, presence of hepatocellular carcinoma, BMI, and any of these comorbidities. So kind of, I don't know, at least in my mind, it would maybe make sense that some of these things would differ by frailty status in this population. They really didn't. So, but all of these things did except for the INR. Okay. So what they found was that, well, they were looking at what predicted mortality while you're waiting for your transplant, not after your transplantation. So they found that if you're frail, your mortality on the transplant wait list was higher than not frail. And they stratified by MELD score too, and it held no matter if your MELD was 18 or over or less than 18. So, I mean, the numbers are here, but you can just see that if you're frail, about 23% were dying while on the wait list compared to if you're not frail in no matter which MELD category you're in. And so if you wanted to kind of put a number on it, every 1 unit increase in your frailty score from 0 to 5 increased your risk of death on the wait list by 45%. That's pretty high. So, and that was adjusted for your MELD score. So it's maybe one other thing in your arsenal to look at in addition to the MELD. So I told you they measured these other things, right? And they wanted to see, like, how does Freed frailty compare to these? So I already kind of told you it was about 45% increased odds, so this hazard ratio, or increased risk, I should say, hazard ratio 1.5, so that means 50% increased risk for death on the wait list if you're frail. The short physical performance battery was predictive too. Every 1 point increase on that score, which implies worse function, gives you a 20% increased risk for death, but it's probably not as big of a predictor as the Freed. And then ADL and IADL was sort of so-so. The ADLs was not predictive. This p-value is not significant. The IADL, a little bit, but that comes very close to 1 here. But then once they adjusted these results for the MELD score, ADL and IADL disability wasn't predictive anymore, but Freed and SPPB were. And so, and the Freed frailty looks to do a better job, so. And I would, well, neither one of these two things take a whole lot of time to do, but it is time that you have to take from all of your other assessments, and I'm sure you guys have a huge long checklist of other things that you're doing, but it's not like, I don't think it's a huge addition. Okay, so, well, I was kind of alluding to that. So gosh, does that mean should we start timing people walking and measuring their grip strength, and we already have a million other things we have to evaluate? And that's sort of the same thing we get in our geriatrics clinic. Well, why are we doing this, and how's it going to impact our care? And in the geriatrics world, there's probably less argument to do it, because we already can tell by looking at them, for the most part, that they're not going to do well, and we're already doing good geriatric medical care anyway. But in your case, you may be able to really tell who's not going to do well, or who's not even going to make it to transplant, and then who's going to die or have complications after the transplant. But there are other methods available that perhaps take less time, although I'm not totally convinced, but they don't involve measuring grip strength and walking speed. So there is another frailty index developed by a guy named Ken Rockwood in Canada, kind of almost about the same time as Linda Fried, although a little later, so she got to it first, and so she's kind of more well known, and her model is the most widely used, but this one is used a fair amount, and it's called a deficit accumulation index, or a frailty index. And the basic premise is that if you measure 30 or more things, and the majority of those things are deranged, you're not going to do well. So, so basically, his first paper actually had 90 things taken from a comprehensive geriatric assessment and history and physical. 90 things you had to check off. Are they bad? You get a 1. If they're not bad, you get a 0. And now he's pared it down to at least 30 things. So he's making it easier. But these checklist things, and this is published too, so if anybody wants to see the checklist, I'm happy to send it to you. But it's like disability and all of the activities that we were kind of talking about, different comorbidities, whether you're sedentary or not, weightless, some of the things that Fried has. If there's a memory deficit, hearing loss, vision impairment, I mean, it's, big, long list. And then you get a score of the number of deficits you have over the total deficits possible, so kind of easy. And if you have a score of 0.25, which I guess that means about a quarter or more are deranged, then you have increased mortality. And, I guess I would say the potential beauty in this, especially for a busy clinician, is that a lot of this stuff you can do with a questionnaire. You're probably already getting this information, or you could pull it from the chart. Anyway, it might be potentially easier. Although I'm going to maintain that the grip strength and the walking speed really doesn't take a whole lot of time. And once you know how to do it, yeah, it's really like 5 minutes maybe. But anyway, this paper, or this group from Canada, put forward that if you have this frailty index and you had a score of about 0.25, then your mortality your mortality or death rate increases significantly, and it only continues to rise from that point on. And you can see that if you're up here, like practically 100% of people who had 0.6, which means 60% of their things were deranged, were dead, and this was over 10 years of follow-up, and this was again from a Canadian population. And then they actually had a paper where they compared how that index, the 0.25 or up, compares with the Fried criteria, which is the non-frail, pre-frail, and frail, and you can see that it kind of tracks along here. So I mean, I guess I would say either one is probably going to tell you who's not going to do well in the long term. Purists of frailty would argue that the frailty index of the multiple deficits is not really classical frailty, because it's including disability and comorbidity, all things that are sort of distinct from frailty, but they both do a good job of predicting mortality. So I think you would not be wrong to use either one. So for the lung transplant people here, this is the only paper that I found looking at frailty predictive of lung transplant. And the reason I went through that whole entire spiel about the index is because that's what they used. They did not use the Fried frailty index. They used the deficit accumulation. And they define frailty as if your index was 0.25 or higher, just like I told you, and they measured 30 different deficits in their patients. And this is survival after the lung transplant, and you can see the people who were frail, really didn't do good pretty much from the beginning there. So it also predicts very well. Okay, in this particular paper, looking at the lung transplant group, interestingly, in my mind, although it predicted mortality, it did not predict how long they were on mechanical ventilation, how long they were in ICU, or how long they were in the hospital. I was kind of actually surprised by that. I would have thought there'd be association. But actually, let me go back to the sample size. They didn't have a whole lot of patients in that study. Maybe if they had a bigger sample size, they would have seen something there. Because in some of these things, it does sort of trend towards higher in the frail, but it wasn't significant. Okay, so I've come to the end. This is sort of a summary of what I hope that I've told you, but I think the take-home point is that frailty, no matter how you measure it, and there's no clear consensus, there are tools available to use that will give you information on who's not going to do well, either waiting for transplant or after transplant, and may help you in your risk stratification prior to transplant. And so I guess I will just stop there, and I want to thank you, and I'd be happy to take any questions that you have. Yes.
Thank you. That was really good.
Thank you.
I just wanted to ask, have you found any evidence that there are interventions to reverse frailty? Because we see a lot of patients who come for evaluation who are very frail. And I think we end up transplanting a lot of patients who are very frail in the hope that transplant will reverse a lot of their frailty.
Okay.
Especially our liver transplant patients, because we think a lot of pre-liver patients have a lot of muscle wasting.
Yes.
And I think there are some papers out there right now where they've, especially coming out of Michigan, where they've shown that muscle mass,
Yes.
psoas muscle mass actually correlates to frailty.
Yes.
And liver patients are known to have muscle wasting. So you
Yes.
think that after transplant they will actually gain muscle mass and they'll probably reverse a lot of their frailty. Is there any evidence behind that, or are there any interventions we can do on our pre-patients to make some very frail people not that frail?
Right. The only intervention that I've seen that kind of reverses frailty is exercise, actually, which some of your patients probably can't do, I'm going to guess. But having said that, the effects of exercise on frailty, at least in some of the studies I reviewed, are not really long-lasting, meaning like after they finish their exercise program, they kind of go back to being frail again. But if you are thinking that you're trying to get them to the transplant, I don't know. I was telling, I haven't seen a transplant patient in a long time, but I have a lot of memories, not so good, of taking care of transplant patients. But I don't know, do you guys use PT prior to transplant? That might be, that's the only thing that I can think of. There's no pharmacologic interventions that I know of or otherwise. I would say PT would be your best bet there.
We are measuring frailty now by a couple of parameters, but
Okay.
we don't know what to do with that data yet, I think.
Yeah.
I don't think we've made a strict cutoff that patients above or below such cutoff will be turned down for transplant,
Right.
or they should be subject to this sort of a regimen.
Right.
That needs to be worked.
That's actually probably a good study. If you could prehab people who are frail and see if that improves their outcomes, I think that would be a really good study. That would be a big one and take money, but yeah.
In the lung transplant program, the physicians look at the 6-minute walk test. They do the SPVD
Okay.
test as well. And if a patient has a score of 8 or less on that performance battery, they do not go to transplant.
Oh, really?
They send them to pulmonary rehab, and if they're
Oh,
able to
okay.
complete
They're already doing it.
rehab, then they tend to be a transplant candidate.
If they finish the pulmonary rehab. See, yeah. Oh, go ahead. I'm sorry. No, I was just going to say, I think your best shot of like preparing people to do well is some kind of physical therapy or exercise. Yeah.